Hey, it's your Ugandan girl here. Oh my god. Sorry about that. Thank you for coming to watch my channel. Thank you for coming to watch my content. I don't take it for granted. I appreciate your effort and I appreciate your time that you put in to watch what I'm sharing, okay? Um, Today we are going to talk about the second emergency birth, and that is it, the PPH, the a second emergency that you may get during birth. Okay, so we are going to do PPH. It's one of the stations I love. guys, I just love PPH. I guess I'm not the only one. So anyways, if this is your first time here, please click the subscribe button so that you get notified every time I post a new video. And then if you're a returning subscriber, please, thank you, I love you. And if you feel this information will benefit anyone who is preparing for their exams, please share with them. Let them come and watch. Let them get a glimpse of what to expect. Okay, so we're going to do the marking criteria first of the PPH, and then we're going to have the how to go about it. Yes, you know, we have the marking criteria, but this does not exhaust about what you're supposed to do. Everything here, there is something how you have to elaborate about it. So that's why I'm laboring to explain and give you two versions of it. However, everything you listen to, make sure that it marks up the marking criteria, what the examiner expects from you. Okay, so the PPH has 15, are they 15? Has 13 marking criteria guidelines. I think you can see that. Yeah, they're 13. So I'm going to read out first the marking criteria, and then I'll go into the how to. Remember what we said about the obstetric emergencies, what we do. Okay, so I have a version of it, and then perfect. Let's go in. Actually, the fact that I love PPH, the fact that I love PPH, I almost feel like giving you 3 versions or 4 versions of how to do it. Anyways, let's go in straight into the assessment criteria, and then we shall go into the how to do it. My aim is to give you variety, so that you check. So, number 1, we're going to be 1A is recognizes this is an emergency, calls for help, recognizing the need to use the emergency buzzer. Remember, I told you, if you are in the community and you get PPH, it is 999. If you're in the hospital and you get an emergency, it is 222. So you call 4 times. Okay, ensure that the baby is in ensure the baby is in a safe place, and such as a cot. Okay, verbally considers the cause of the hemorrhage. Remember that the 4 T's, what we expect to be the causes of the hemorrhage. So we have tone, we have tissue, we have trauma, and we have thrombin. So try to find out the cause of the PPH that the mother is having. Then supports the woman to lie back and commences high flow oxygen using a non-breather mask. Wraps the uterine contraction. This must be demonstrated. Ensures that the uterus is well contracted and the clots are expelled. Verbalization is accepted on that, because remember, you're using a dummy. Okay. Checks the placenta. Verbalization accepted. Verbally identifies the need to check for trauma. Remember, you need to identify which trauma it is, and you mention them, so that examiner knows you know what you're talking about. Okay. Then verbally identifies the need to cite 2 large bore cannulas in each arm, one on each arm. So if you put one here, another one here, one is for in, one is for out. Out are those the bloods that are being taken off to the lab, okay? In are the fluids that are being given, okay? I want you to just understand that. One is in, one is out. So one, just know they're taking out bloods for these checks, and then this one, the crystallite fluids are going to give, okay? So then we're going to verbally identifies the need to take off blood for urgent samples and states the blood required. I'll explain that when we go into the details, the blood which are required in the how to, okay? Then verbalizes the need to commence fluid resuscitation using crystallite infusion, e.g. Hartmann's solution, or 0.9% sodium chloride. So we've put the two cannulas to use already, okay? Then verbally identifies the need to identifies the need to catheterize the urinary bladder using an indwelling Foley catheter. Then identifies appropriate physiological observations to take and potential indicators of shock. Do you know the idea, the indicators of shock? Okay. Then verbally considers appropriate medication to stop the bleeding. Hello, midwives, are you listening? Miss Bristol or what? Okay. Then performs bimanual compression of the uterus, clearly verbalizing the appropriate steps. Verbally considers the options that might be taken by the medical team if bleeding is not settled. Verbalizes the need for the midwife to ensure the woman understands what has happened and the chance to bond with her baby. That's what we talked about, debrief. Remember at the end we said in the previous video that we have to debrief, detox, document. Okay, when you're debriefing the mother and you're debriefing the team that you called. Okay, then verbalizes the importance for maternal observations to establish condition and established weight loss, blood loss, okay. Then verbalizes the importance of completing all relevant documentation, including the Muse chart. Acts professionally throughout the procedure in accordance with the NMC 2018, the Code, Professional Standards of Practice and Behavior for nurses, midwives, and nursing associates. So now that's done. That is the marking criteria. Let's now go into the how. Guys, I know you'll fall in love with PPH too. Oh my god, I'm tired of sitting, trying to adjust myself, sorry. Okay, so let's begin with, this is situation one, okay? You're going to go like, oh, my mother is Jamira, okay? So when I say Jamira, that's the mother I'm working on, okay? So let's assume you're already in the process of doing the delivery. I know the mother knows me, and I know the mother knows me. So Jamira knows me, and she knows I'm the midwife who has been working on her. So I've already drawn the curtains for privacy and dignity, and I've already had my apron, gloves, and I've already washed my hands based on the World Health Organization. I see Jamira bleeding. I recognize it's an emergency situation, which is postpartum hemorrhage, and I'll let the mother know I'm going to call for help. I'll let her know that she's having PPH and I'm going to call for help. So let her remain calm when she sees other people who are coming. They're coming to help the emergency situation that I have, okay? First, I'll ensure that the baby is in a safe place, like a cot. This is the baby. I'll make sure the baby is in a safe place, like a cot, okay? And okay, Jamira, a lot of people come in, such as the senior midwife, obstetrician, anesthetist, the scribe, and I'll be calling 222 for them to come, okay? First, we first consider the foremost causes of hemorrhage, which are tissue, trauma, thrombin, and tissue, trauma, thrombin, and tone. Okay, Then I will lie back. I'll make Jamila lie back and remove the pillow and ask for assistance to bring the emergency postpartum box. Okay. I will commence high flow oxygen 151 per minute by a rebreather mask and start rubbing the uterus to make sure clots are expelled. Okay. I will ask my assistants to commence 2 large bore cannulations to commence resuscitation with my Hartmann solution or 9% sodium chloride, which is saline, normal saline. Then I'll take off the blood for urgent blood samples, including full blood count, clotting studies, renal and liver function test, cross match, 4 to 6 units, because we don't know how much the mother is going to lose. Okay. Then I will catheterize the urinary bladder with a Foley catheter. With a urine meter. So I'll check the input and the output. Okay. At this point, I'll perform observations such as pulse, respirations, blood pressure, oxygen saturation. I'll consider signs of shock like tachycardia, which is below 100 beats per minute, and then I'll consider a respiratory rate which is higher than 30 beats per minute, and systolic blood pressure which is below 100 milligrams. Examiner, what is the amount of bleeding? So at this point, I will assess the blood loss, and if it is still continuing, I will consider administering medication to stop bleeding. The second dose of symptometrin, 10 international units, will be given IM. Okay. So the symptometrin infusion, 40 units, IV over 4 hours in 500 mils of sodium chloride via a pump, 125 mils per hour. Okay. Then we will also look at egometrin, 500 milligrams in IM, which is contraindicated in a mother who has high blood pressure. Okay. Then we also look at carboprost, 250 milligrams IM, every 15 minutes up to 8 doses, which is contraindicated in asthma. Then we also look at tranexamic acid, 1 gram, slow IV IM, 1 ml per minute. Okay. Then in the same time, performed by manual compression, one hand is inserted into the vagina by manual compression. So you make your hand like this on the cone. You support the uterus above that. You support the uterus abdominally, and then this is how you go in, cone shaped. Okay. In the same time, performed by manual compression, one hand is inserted into the vagina, which applies pressure to the uterus anterior wall, and then the other hand applies pressure externally on the uterine fundus. So this is supporting the fundus here. Okay. So sorry, my baby boss, this goes in, and then you form a fist. When you form a fist, and this is it, how you apply pressure. This one is over the abdomen. This is small, that's why it appears like this is over there, but this is inside the vagina. Sorry. And then we look at commencing blood transfusion with ISO group. With isopaxil in the maternity ward. So we may use rhesus negative blood. So because it's a universal what? How do I call it? Universal blood that is given to everyone. Okay. Then if the bleeding does not settle, then we shall do examination under anesthesia to manually remove the retained products. So this means the mother is going to be taken to theater. Okay. So repair of undiagnosed vaginal and cervical tears will also take place. Uterine balloon tamponade can be also done. Then the B-Lynch suture technique, that's how it's called. Then also hysterectomy may be done if the mother completely fails to So hysterectomy will also be considered in case the mother fails completely to stop bleeding. Okay, so you go back to Jamira and tell her, Jamira, you had massive bleeding, which is called postpartum hemorrhage, and you had to do some actions to stop the bleeding. Once you are sorted, I will ensure that you see your baby and start skin to skin contact. Again, I will consider doing my maternal observations and document on the Muse chart and score it to detect maternal signs of shock and check output and input every hour. So I'll go on to dispose my PPE, clean my hands. That's it. So that's one. Should we go to the second one? I'm giving other ways so that you can see which one is easier for you to do. Which one can you relate to, okay? Which one do you feel is easier? They all cover the main things you're supposed to do, but which one do you feel, do you understand quickly, okay? So then we're going to look at sorry for that delay. I'm trying to see which one should I give you first. The second, the third. I have like 4 ways. How many do you want? All right. So let's assume I'm starting the second one. Let's assume the baby is in the cot. I'll wash my hands, put on my gloves, my apron, and I'll draw curtains. I'll look to see that the environment is safe for me and the mother. And then, okay, Jamira, I have been. Let me have a look at your perineum. Is that okay with you? Okay. So you are bleeding too much and this is an emergency. Okay, I will call the emergency buzzer. 2222. This is midwife Sarah and I'm in postnatal ward. Postnatal ward. You're not in postnatal. Yeah, PPH can be in postnatal. Yeah, I can say, okay, postnatal ward about, okay. In postnatal ward room number 3, I'm having severe PPH. The patient delivered 2 hours back. Okay. Remember, you need to state exactly where you are, the room number, your name, and consent while the people come in quick, okay? I'll need a senior midwife in charge. I'll need the obstetrician. I'll need the anesthetist to come and. So I will draw all the pillows, give the mother a high flow oxygen using a non-breather mask. I'll palpate the abdomen to look at the fundus and see if clots are coming out. Notice the cause of PPH, which may be either tissue, trauma, thrombin, or torn. Tissue, trauma, thrombin, or torn. Remember those what is? Tissue, trauma, thrombin, or torn. Tissue, trauma, thrombin, torn. Tissue, trauma, thrombin, torn. Tissue, trauma, thrombin, torn. Tissue, trauma, thrombin, torn. I'm repeating it so that you also grasp it. Okay. Then I'll notice the estimated blood loss in mils. Okay. Then I will the emergency team I've called, they will have come. So then I'll ask one of the colleagues to put 2 large bore cannulas, 1 on each arm, 1 on the other. 1 for out. 1 for out, we shall take off blood for blood group, cross match, blood count, liver function test, and an indwelling catheter for the urine, input and output. That's the out. Then we give a second dose of oxytocin to help the uterus to contract and control bleeding. That is 10. We also give the 10 IM, I repeat one, as I massage the uterus to see if there are any clots coming. Then I also give IV fluids, e.g. Hartmann solution or sodium chloride, which is 0.9 saline, and rapid infusion of the saline. Then in the saline I'll put the 500 in the 500 mils of saline I'll put 40 international units of oxytocin. Are we together? Then I'll let it flow at 125 mils per hour. So how many hours are looking at for you to infuse 125? To infuse 500, those are 4 hours of infusion. If the mother gets 125 per hour, okay? So then the doctors will have come, so I will continue to massage the uterus to see if there is any bleeding and explore the birth canal to see if there are any undiagnosed tears, episiotomy repair of first or second degree tear. Then if it is a second or fourth, if it is a third or fourth degree tear, this mother will need to go to theater for repair, okay? So since the doctor will have come, they will prescribe for me misoprostol 100 to 1,000 micrograms, which will be given per rectal to control bleeding. Remember I talked about MCG. So if the mother is still bleeding, we shall consider doing an internal uterine massage, whereby I will give the mother a painkiller and then stabilize the mother's uterus per abdomen. Make my hand into a cupped Pringle-like manner, access the posterior fornices of the vagina, make a fist, and I firmly and gently apply pressure on the uterus to contract and control bleeding. If the mother is still bleeding, we shall take her to theater under anesthesia, and they may do visualization to see internal tears or the cervical tears. If the mother is still bleeding, they will do a uterine suture. If it is still bleeding, the doctor may consider doing a total hysterectomy to save the mother's life, okay? If Jamira's condition is okay and if it allows, I'll let her bond with the baby and initiate breastfeeding. Hello? Have you seen the slight difference? So then I will do my documentation. When I notice the PPH, I'll do my documentation, but remember we talked about the contemporaneous information. Noticed when the BPH started, the medication given, so you make sure you try to write that. I call the contemporaneous notes to be scanty notes, but the scanty notes should be at least in detail, okay? So then we go back to our 3Ds, where we have to debrief the mother, debrief the team that came to help you out, and then you tell them everything that happened, and then remember to detics. Okay? Debrief, detics, document. So I will have monitored my mother's OBS and check for also the signs of shock. I mentioned the signs of shock in the previous explanation. So the low blood pressure, low hypo, or the mother may also be hypothermic. So you do it every 15 minutes until the mother gets better. So I'll continue monitoring the mother's PPH. Wash my hands. Continue monitoring. Any question? Are we together? Can we go to the third one? I want you to pick a note of each of what you want. What have you heard? Are you doing? Okay, so for the third one, I just wanted to make sure I'm just noting out key points in this management, okay? It's not giving a whole third one. So I just want you to note out the main points that you've also had in the previous two. Yes, they look a bit similar. They were just small, whereby one had MCG, another one did not have. Okay, so one had misoprostol, the other did not have. I think you noticed the difference if you were listening clearly. So this is for the main points of PPH. You must recognize it is an emergency situation. You should verbalize this. Then you should go on and pull the emergency buzzer. Okay? remember to call 999 if you are in the community. You call 2222 if you're in the hospital. You recognize the need for help, so you need to call the senior midwife, obstetrician, anesthesiologist, then the scribe or other midwives, or other midwives. Okay, verbalize the PPH is caused by 4 things. Remember, we said that tone, thrombin, trauma, and tears. Okay, so then we shall go on to support the woman to lie down on her back. Remove the extra pillows. After removing the extra pillows, start the high flow oxygen with a non-breather mask. Make sure you know that how the non-breather mask it looks like. Okay, then you demonstrate on the dummy how to roll out how to rub a uterine contraction. Okay, to see that the mother's uterus is either is what? How to rub the uterus for a contraction. Then remember to put in 2 large bore cannulas, 1 in and 1 out. The 1 in is going to start the crystallite solutions, which may be Hartmann solution or sodium chloride, which is 0.9, or saline, normal saline. Sorry, I play too much sometimes. Then we shall go on to sorry. Remember the out the bloods that we take off. That's what that. So remember the bloods that I told you that we take off the out for in the previous explanation. So let's go on and perform the maternal observations, and also recognize that the mother is not running into hypovolemic shock. So hypovolemic shock is you've heard about it, and so what are the signs of the hypovolemic shock? So this is hypotension of the systolic blood pressure, which is less than 100. Capillary refill, which is greater than 2 seconds. This should be less than. Then we have tachycardia, which is above 100 beats per minute. Then we have tachypnea, which is excessive breathing above 30 breaths per minute. Okay, then you verbalize that you're going to intervene with medication. Okay, the medication that we expect you to talk about is symptometrin. Some people use egometrin, but remember it is contraindicated in women who have high blood pressure, so you should be careful when mentioning it. You should be able to talk about people who are hypertensive. Then we do carbaperos, then we do tranexamic acid, we have misoprostol, we have oxytocin, which you can give, which is the infusion, which you give 40 units, international units, and then you also give IM, more 10 IM. Okay, then you go on to perform the bimanual. If that does not work, then we go on to perform the bimanual compression. I've already showed you how to do that, so you can verbalize it. You put your hand into the cone cone shape, put it in, and then do compress. Okay, again, the fundus. If bleeding does not stop, then you need to verbalize that the anesthetist needs to come and take the woman to theater. Manual removal of the placenta and diagnosed tears, uterine balloon tamponade, or hysterectomy will be performed. Okay, debrief the woman about why each step was done, any effect, perform your observations, and make sure she's not running into shock. So document and continue monitoring. In case the mother is fine, please make sure she starts bonding with the baby. I'm thirsty. Thank you for watching. Thank you for watching. Me and my baby want you to love PPH, don't you? Me and my baby want you to love PPH, okay? Love you. Thanks for watching. Come back again.